Good morning, students. Today's lecture is on hemolytic anemias. The learning outcomes of this lecture are listed here. Today I will be discussing on two important hemolytic anemias, that is thalassemia and sickle cell anemia. Before coming to hemolytic anemia, let me define what is anemia. Anemia is defined as a reduction in total circulating red cell mass below normal limits. In real life, it is difficult to assess the red cell mass. So for all practical purposes, we take a reduction in hemoglobin as anemia. Etiologically, there are three types of anemias, and morphologically also there are three types of anemias. The type of anemia that we see in hemolytic anemia is normocytic normochromic. So let me define what is hemolytic anemia. Hemolytic anemia is a form of anemia due to hemolysis, that is abnormal breakdown of RBCs, which takes place either inside blood vessels or outside the blood vessel. When it occurs inside the blood vessel, we call it as intravascular hemolysis. And when it takes place outside the blood vessel, we call it as extravascular hemolysis. The common area where extravascular hemolysis occurs is in the spleen. In intravascular hemolysis, the patient usually presents with anemia, hemoglobinemia, hemoglobinuria, hemosidenuria, and jaundice. Whereas in extravascular hemolysis, the presenting features are anemia, splenomegaly, and jaundice. In this slide, you can see two pictures. One is examining for anemia and second is examining for jaundice. In the first picture, if you look at the conjunctiva is pale, indicating that the patient has got anemia. The second picture is showing yellowish discoloration of the sclera when the patient is looking to the sides. It indicates jaundice. Jaundice is examined under broad daylight. Coming to the classification of hemolytic anemias, hemolytic anemias can be classified as hereditary and acquired. Hereditary is further subdivided into membrane disorders, enzyme disorders, and hemoglobin abnormalities. Example of membrane disorder is spherocytosis. Enzyme disorder is G6PD deficiency, and hemoglobin abnormalities is thalassemia and sickle cell anemia. Acquired hemolytic anemias includes antibody-mediated hemolytic anemias. Example is transfusion reactions, mechanical trauma, hemolytic anemias due to infections, and toxins. All hemolytic anemia shows increased number of normoblasts in the bone marrow. If you examine the peripheral smear, there will be increase in reticulocytosis. There is accumulation of hemosiderin in the spleen, liver, and bone marrow. And in chronic hemolysis cases, there is increase in pigment stone formation. This slide shows erythroid hyperplasia, which is very typical of all hemolytic anemias. Let me come to the first topic of thalassemias. Thalassemias are grouped as thalassemia syndromes. Thalassemia syndromes are a group of disorders caused by mutations that decrease the synthesis of adult hemoglobin. Adult hemoglobin is alpha 2 beta 2. Beta thalassemia is caused by deficient synthesis of beta chain, whereas alpha thalassemia is caused by a deficient synthesis of alpha chain. Thalassemia syndromes are more common in the Mediterranean basin, in the Middle East, tropical Africa, Indian subcontinent, and in some parts of Asia. This is the most common inherited disorder of human beings. Coming to the classification of thalassemias, thalassemias can be classified into beta thalassemia and alpha thalassemias. Beta thalassemias are further subdivided into beta thalassemia major, minor, and intermediate. Alpha thalassemia includes silent carrier, alpha thalassemia trait, HPH disease, and hydrops fetalis. This slide shows the pathogenesis of a case of beta thalassemia major. I will briefly explain the mechanism whereby beta thalassemia is produced. In the picture, you can see that there is a normal erythroblast, which usually gets converted to RBC. So, in a case of beta thalassemia, there is reduced production of beta chain. So, there is a relative increase in alpha chain. This relative increase in alpha chain will precipitate on the surface of erythroblast as insoluble precursors. So you get the formation of an abnormal erythroblast. This abnormal erythroblast undergoes ineffective erythropoiesis, which results in anemia. When this abnormal erythroblast passes through the splenic sinusoids, there is hemolysis. So this contributes to extravascular hemolysis. Ineffective erythropoiesis with extravascular hemolysis contributes to anemia in a case of thalassemia. So there is both intravascular hemolysis and extravascular hemolysis taking place in a case of thalassemia major. Coming to the investigation parts in a case of thalassemia, there are different investigations which are done in a case of thalassemia, which includes complete blood count, peripheral smear, and other investigations. So here you can see a peripheral smear. If you look at the peripheral smear, we can see RBCs and platelets. WBCs are not seen in this smear. If you look at the RBCs, the predominant cell that we see are the target cells. There are microcytes, there are teardrop cells, along with teardrop cells, we can see the presence of enucleated RBC. So there is anisocytosis. Anisocytosis means difference in size of the RBCs. Even the shape of RBCs are different. So there is poikilocytosis. So the peripheral smear is showing anisopoikilocytosis with presence of nucleated RBCs. The confirmatory investigation used to diagnose a case of thalassemia is hemoglobin electrophoresis. After doing complete blood count and peripheral smear, we can do a hemoglobin electrophoresis which confirms beta thalassemia. Serum bilirubin levels are increased. If we do a DNA analysis, DNA test is not routine but can help diagnose thalassemia and determine carrier status. The second type of hemolytic anemia, which I will be discussing today, is sickle cell disease. Sickle cell disease is a common hereditary hemoglobinopathy that occurs primarily in individuals of African descent. Normal hemoglobin is alpha 2 beta 2. Point mutations in the 6th codon of beta chain, where there is replacement of glutamate with valine, will result in the formation of HBS. HBS is the pathology in a case of sickle cell disease. This slide shows the pathogenesis of a case of sickle cell disease. Normal hemoglobin is HPA. When there is point mutation, HPA gets converted to HPS. HPS, when it undergoes deoxygenation, potassium and water will go out of the RBC and calcium will enter the RBC. Repeated episodes of deoxygenation will produce what is known as an irreversibly sickled cell, which undergoes intravascular hemolysis as well as extravascular hemolysis. If there is oxygenation, the cell reverts back to normal. So the presence of irreversibly sickle cells is the pathology of sickle cell disease. So basically there is hemolysis, which is both intravascular and extravascular, and these irreversibly sickle cells will stick to one another, causing microvascular occlusion. So microvascular occlusion can lead to tissue damage. The investigations in a case of sickle cell anemia includes complete blood count, where the hemoglobin levels will be reduced. And as you can see here, we are seeing a peripheral smear. If you look at the peripheral smear, RBCs are of different size and shape. That is, there is anisopoikilocytosis. Neutrophils can be seen and platelets are also present in the smear. In between the RBCs, we find sickle-shaped cells, which are nothing but sickle cells. There is also presence of target cells. A case of sickle cell anemia can lead to various complications, which includes increased risk of severe bacterial infections with pneumococcus and H. influenza. Patients can go in for stroke. There can be gallstone formation. Priapism and infarction of testis are other complications which can occur in a case of sickle cell anemia. Osteomyelitis or bacterial bone infection. The most common cause of osteomyelitis in sickle cell disease is Salmonella. Patients can go in for heart failure, renal failure, and leg ulcers. Diagnosis is based on complete blood count, peripheral smear, and sickling test. It's confirmed by hemoglobin electrophoresis. Peripheral smear shows anisopoikilocytosis with presence of sickle cells. Sickling test is done using sodium metabisulfite. A drop of blood is taken on a slide and one drop of sodium metasulfate is added onto the slide. It's covered with a cover slip and the sides of the cover slip are sealed, and it is examined under the microscope. Presence of sickle cell indicates sickle cell disease. These are the references, and if you are having any doubt, you can feel free to ask me at the end of this class. Thank you very much.